I welcome all my expert panelists, Dr. Khalid, Bhatti, Dr. Mukesh, Dr. Mahesh, and Dr. Hina. The topic of my presentation today, it is basically a case scenario presentation on left main intervention and bifurcating disease. My name is Dr. Faiza. I'm working as a consultant intervention cardiologist in NICUD Karachi. Directly coming to the case, this was a 69-year-old male with previous no comorbids, presented to the clinic with unstable angina, a C6 class 2 angina. The EKG showed a T-wave inversions in the chest leads. Echo performed a preserved cardiac EF and dimensions. Because of his worsening angina, he was taking for a coronary angiogram. This is the LV-gram showing apical hypokinesia with preserved function. The right side, which showed a dominant RCA with a moderate disease in the proximal segment, diffuse disease. There was a severe disease in the osteoproximal segment of the PTA and a severe disease in the right PLV. Left system engaged, and I know most of them, after looking at this, must have had a minor heart attack ourselves. So showing a caudal view with a severe disease in the distal left main and a severe disease in the osteoproximal RCA, tubular disease, with a TIMI2 flow. The cranial view also showed a severe disease in the osteoproximal LAD with a TIMI2 flow. This is the spider view for your better visualization. No further shots were taken because of the critical anatomy. After going to this angiogram, I would like to ask my expert panelist, what would have been your call if you had seen an anatomy disease like this and it was your patient?
Thank you, Dr. Faiza. I think it's a complex anatomy involving the ostial circ as well. Already you say it's a ostial or distal left main with ostium LAD involvement and circ. It's a complex anatomy. But in this scenario, you will see is already AC is having an unstable angina, and with such symptoms, I think it's a TIMI2 flow. So we have to intervene, and I don't think we have to wait for surgery. And although we have two indication for such type of diseases.
Definitely, the new guidelines.
So we can have now good results of two-stent strategy, but we can think about one stent. But I think in this patient having a side branch involvement which is more than looks to be 10 millimeter, which already our discussion in the morning, they said if disease has involvement of side branch with ostium more than 10 millimeter. So DK crush has a lot of good results with good trials. DK crush from 1 to 5, they all having a good impact on left main stunting. So I think we should proceed with two-stunt strategy. The rest of my friends, what will they say? And from audience, anyone can suggest anyone opinion from about it.
So what do you think, Dr. Mahesh? Do you agree with this?
Yes, we have already gone through this discussion.
Yes, a lot of left
morning.
Yes.
And this to me is not a case of provisional strategy, because there are the 2 and 3 things which are having the direct two-stent strategy. One, the lesion is very critical in the circ. Looking at the angle, it is more than, I think so, more than 75.
Yes.
And the lesion is very long. And in those cases where the wire, passing of the wire is difficult, when you think that you will be unable to cross the lesion again, so it would be better to go for direct two-stent strategy apart from the provisional. Though the provisional is very good, but again the data favors now after the DK Crush 5 trial that you can go for direct DK double kissing strategy.
Yes, but the study says that if it's a difficult rewiring, you should always consider stenting of the side branch first. Yes, Dr. Mukesh, you would like to come in?
First of all, when we decide to intervene the left main, we should know about the clinical and anatomical regarding the left main.
I know you are post-call.
Reverse correction. The thing is that first we created a syntax score.
Yes.
And now recent days we have a new invention in devices, in techniques, urging the pharmacotherapy and the expertise. One who doing the left main PCI, he should know the step by step regarding the bifurcation. And another thing is that when we are doing the left main PCI, though in the traditionally we see the cabbage is the gold standard reverse correction method over the medical therapy.
this established mortality benefit along with the durability. But as far as concerned regarding our data, if you see the data, recently we have, Dr. Naveed also discussed the DKK5 trial.
Yes.
The reason behind to do the PCI for left main is the establishment of the imaging. If you see detail go in the data, 71% in DKK5 trial and 71% in the EBC main trial. They use the imaging.
Yes.
That's why due to the imaging help a lot of us, but still there is unresolved and unmet issue regarding the PCI the left main.
Yes.
Last, I want to comment on this. If still we have doubt or we are not taking proper decision, we have to discuss in heart team. What the heart team said to such type of lesions, what is their experience, they should share us.
Definitely. Coming back, so if I just precise it, what the panelists have said, imaging for left main has to be the number one thing. You need to have imaging in your hand. Heart team, definitely, without discussing if this is a heart team, we cannot take it. And the other thing is that it's a complex anatomy, left main bifurcating anatomy. And for this, I'll go through it. The guidelines can say that we have to go for dedicated two-stent strategies. This was unstable angina. The indication. Yes. To come up to bat, this patient was done in one of the satellite centers, and he was taking over there. The indication was unstable angina, and when he presented to us, he still had pain, CCS class 2 angina, but he was referred to the main center.
He was maintaining blood pressure.
He was completely stable when he presented to us. So I'm not going to go into the...
one more point. Left system is filling from the RCA, and the patient is hemodynamically stable. Why not to consider cabbage in this patient?
I told you, yes.
Distal targets are very well, and
this was discussed in the heart team, and we properly went through it, and we had a heart team discussion, and then we took the patient on the table after the heart team and patient preferences both. So these are some of the issues which we will be dealing. I'm not going to go into the detail because we have heard so much of left main today. Like whenever we say distal left main, we all know that it's 70% of the lesion is 70 distal left main locations. We have a multivessel disease and mostly calcification is seen. Common classification, Medina, it is just a simple, we have gone through a lot of classifications today. This is the simplest classification that we can remember, 111, the proximal, the distal and the side branch. Going to it beyond the Medina classification, we need to know what is a true bifurcation and what versus a non-true bifurcation. Whenever we think of a bifurcating techniques, a true bifurcation is those which has a side branch involvement and a proximal and a distal one, a side branch with a proximal and a side branch with either a distal. So either 111, 101 or 011 is a true bifurcating disease. Going back to the left main, this was a definition study which further classified two bifurcating lesions into a simple true versus a true complex true bifurcating disease. Why I'm telling you all this? Because on basis of these, we opted for the next strategies which we planned for. So a complex lesion is one which meets one of the major criteria and two of the minor criteria. What is the major criteria? It's basically a side branch with a diameter of 2.5 and a lesion of greater than 10 mm, with a left main of greater than 70% stenosis, and if a non-left main of greater than 90% stenosis. So our patient fell into the first line, the left main bifurcation with a side branch of greater than 10 and a stenosis of greater than 70%. The minor criteria which our patient fulfilled were calcification and the angulation. So this was the most updated 2017 JACC study, which showed that if it's a simple lesion, less than 70%, we can go for a simple provisional technique. But when we are considering a left main complex lesion, our two-stent strategy should be preferred according to the Asian bifurcation consensus, most probably a DK crush. IVA stenosity mandatory for a left main stenting. The syntax score calculated was 34 of this patient. The 4-year mortality was 8.3% for PCI and 7.7% for the cabbage. So basically, either a cabbage or PCI was favorable. Patient was taken for a heart team. and was advised for percutaneous intervention. So after all the heart team and discussion, we took him for DK cash strategy. Femoral approach was taken, EBO 7 French 3.5 guide was taken, workhorse wires were taken. This was approximately done 10 days after the first angio. We can clearly see the further advanced aggravation of the disease and a TIMI2 flow in the circ.
So when you decided that the patient would be brought for PCI, did you put the patient on antiplatelets for how long?
Definitely, he was already taking antiplatelets, and we had him since because we had him admitted in the ward. He was already taking the antiplatelets, and
was what was the patient's EL?
it was 50%.
Was 50%.
Yes, with the preserved cardiac dimensions.
Because the patient also has Prox RCA disease, the faint collaterals, and the left main is subtotally occluded.
Yes.
Right? So now if I told you the patient's EF was 15%, 1.5, how would your strategy be different?
I think if patient having a low ejection fraction with such an not mean, I will always consider for the mechanical circulatory support device at instance before proceeding or embarking for the intervention. Yes, definitely we know as compared to IABP, Impella having a good outcome in these patients based on the IMPRESS trial. But yes, as we are having availability of IABP, would have definitely gone for the IABP placement beforehand.
I know the cabbage, just mind to but this patient was present with this not be along with the severe liver symptoms. That's how cabbage are better.
Definitely, but cabbage has already been turned down by the surgeon. So once we have decided that we are planning for the PCA percutaneous intervention, there's no need this time to say again for the cabbage opinion because it was taken after the her team discussion.
Just one, maybe question or comment. If this would have been the case, you have taken right from the beginning, like this is a patient presented to you and you did the cath and the patient was symptomatic, you said unstable angina, which is definitely a type of acute coronary syndrome. So at that moment, what would you have decided?
This is 7 French guide cases.
Yes, yes.
To me, it looks like left main is not more than 2 and 2.5 millimeter, maybe 2.5 millimeter. According to finite law, what we have studied today, this left main should be 4.5 or 5 millimeters.
Yes, definitely.
These kind of cases, if I could have done this case, there is no doubt अभी ये बात discussion नहीं करते कि surgery या वो अब this patient you have taken on the table, but what I think I could have done differently, I must take balloon, wire, everything with me and just engaging, putting a wire in which vessel it will go, just pre-dilate it with 2.5 balloon.
Yes.
Then decide what to do next because this is very high risk patient. It seems to be high risk.
Coming back to your question, Dr. Kaman, definitely it would have been a different scenario if a patient has severe symptoms. But as I told you, even after the injury, he was completely stable. So, and we definitely preloaded the vessel with the guide with the wires and the balloon. And you can see that we did not wasted anything. This is the next shot immediately. The wire, the run-through wire was taken and it was went into the LED. And you can see that the TIMI flow is approximately 0 in the LED. So it was pre-dilated. Immediately we pre-dilated the left main, and you can clearly see in the flow in the distal left main. And after the pre-dilatation, we attempted to wire the circ. And because of the wide angulation, it was a very difficult wiring, and it literally took us a lot of time to wire. Yes, Dr. Kim.
What would be the strategy? You see, there's a wire attached in an AMS. What tools do you have, or how would you try to approach this circ to wire? What options do you have available?
we can wire circ.
You can use a different strategy. If you are unable to cross the wire to the circ at this instance because your wire may be prolapsing directly into the ramus, which is very straight one, if you look at the left main, then you can use multiple techniques. Either you can do double lumen catheter if you have. Nobody, you can use the hairpin technique of the wire. You cross it and then pull it and slide it.
Reshape the wires,
yes. Again, you can reshape the wire, you can take pre-shaped wires, there are so many other things
we can change into the polymer coated wires. But definitely ultimate thought can be, the help of a double.
Again, you can do the block the ostial of the ramus. If your wire is continuously prolapsing into the ramus, take the balloon over the ostial ramus, block it, and then try to cross the circ if it is possible.
Both micro catheter Supercross Ninja, you can use it. It is a dedicated for side branch.
Okay.
There are new catheters, micro catheters we can use. They are angled, so we can cross it with that.
So, coming back to it, ultimately we were able to wire the circ with approximately, I think, around 10 to 15 minutes of fluoro. So immediately the circ was pre-dilated with the 2O15 balloon, and the LED was also pre-dilated. And ultimate 3 flows was achieved with a no distal dissection noted.
So out of so many mentioned techniques that the panelists have, so what technique did you use for?
We were ultimately able to go with the workhorse wire. We did had yes.
Technique.
We just changed its wire shape, the reshaping of the wire.
It's not very difficult. Again, sometimes.
Yes, it did give us a hard time.
Sometimes. See, I think for the circ, you're all used to putting primary bands and then secondary bands. So sometimes you have to give it a tertiary band. So, and then take the wire in the LED, and on the way back, that tertiary band gives it support against the greater curvature of the LED and helps the tip go in the circ.
Yes.
So I think that's probably worked.
The shaping of the wire, they say that the second tertiary curve has to be according to the diameter of the left main. You shape it according to that so that it gets support from the left main and then it deflects back into the side branch. So this was the angiographic result after the pre-dilatation. We were able to achieve a TIMI-3 flow, and hemodynamics was stable. We did have the IBP available in the cath lab, but it was not needed. And no distal dissection. Yes. Now what is the plan? What would you like to go ahead with?
Our plan
yes,
is
Dr. Hina.
I would go for upfront two-stent strategy. And in this case, I think DK crush would be more appropriate.
Okay. Would you like to have anything in before that? Would you like to do anything?
Imaging is necessary.
Yes, definitely. Thinking of a complex bifurcating technique, never to forget imaging.
DK crush is because we have a lot of data on it, and it depends upon the expertise of local operator, what he think about it. That's also very important. At that situation, what the operator wants to do.
So this was a left main this was the imaging, IVUS imaging from LED to left main. We can see a calcification at the arc of 1 to 4 o'clock and an arc of 80 degrees. A lot of plaque burden. The MLA at the LED was approximately less than 4, and when that of the left main, it was approximately 2 to 3. So definitely we planned, and the IVUS image for the circ is not available right now, but it also showed an MLA of less than after the, yes.
My question is, why IVUS needed at this point of time?
Yes, definitely that we, I was thinking somebody would ask that, because initially we were so scared of doing the image at the front because of the, the severity of the disease. We pre-dilated it and then we took for the IVUS.
Probably this point of view, this point of time, you need IVUS to select proper size of a stent, because there is no doubt it's severe disease. You have already ballooned it, and you are committed that you are going to fix both lesions.
Yes.
So it will help only in a way to select the stent size at this point of time.
Okay, thank you. So What we did next was a protection balloon placed. So our strategy was, finally we decided go for a decay crush. A protection balloon was placed in the LED. The protection balloon currently was 2/15 because, yes. Then we deployed a 3/22 resolute integrity stent in the circ. 2 to 3 mm was protruded into the ostium of the in the LED. Was the LED? That was LED.
That was the LED run that she showed.
Yes.
I was from the start.
Next step was the side branch optimization. We pulled the stent strut into the bit into 2 to 3 mm into the left main, and it was optimized. So at 18 to 20. So my colleagues, do you think this was like appropriate? Would have been done or not? Some of you, the side branch optimization.
Optimization of side branch is important to protect the ostium of the that vessel. So that's why usually we use this.
Yes, because one of the major side effects after dedicated complex technique, which is the most important side of a restenosis, mostly it's the ostium of the side branch. So it was done, this is a new technique, basically not shown in the old decay crush techniques, that we better use a side branch optimization, and a high pressure ballooning should be done to further enlarge the ostium of the circ. Finally, the wires and the balloon were removed from the side branch, and the recently implanted stent was crushed with the protection balloon placed in the left main to LED. Yes. Yes. Sure.
You did a pre-balloon with NC or?
No, it was a pre-dilatation balloon. We did not use the NC.
While I was sure there is a calcium also.
Yes, but yes, it did show. We planned for, if the stent wouldn't have gone, we would have definitely gone. But it was not that severe. The arc was 80 degrees, and it was not that severe calcification. So after the crushing of the side branch of the circ stent, first spot was done.
What was the size of this crushing balloon?
This is the this balloon is 2/15, the same crush balloon, but then we again sequentially increased. This is a 3/12 NC balloon. We first crushed this, and then we did the pot for this balloon.
When you crushed the stent, did you remove the wire?
Yes, definitely. You can see we don't have the wire in the. Yes, you can jail the wire in the circ. It's up to the operator if you want to jail it, but we were not comfortable with it, so we removed the wire.
Okay, may I suggest to the panelists, if you don't take the discussion, the crowd is eager to speak. So you have to keep the ball in your court. Otherwise, these guys won't give you a
Please keep quiet.
I think
So-
that's the right time to tell, because the panelists are just watching us. So I'm really sorry on the behalf of everyone.
So the next step was the rewiring of the circ. Rewiring was done via non-distal strut. It's basically said non-distal strut, either a proximal or the central, whatever part of the crust segment. And the first kissing balloon inflation was done with a 3/15 and a 3/12 NC balloons. Right after the first kiss, we planned to the circ wire and the balloons, both balloons in the circ and the LED were removed, and a 3.522 resolute onyx stent was placed from the ostial left main to the LED.
Madam, before recrossing the circ wire, did you consider a pot?
I think you just, we did the pot. The pot was done before. Then it was the kiss, and then the left main stent. Yes, I showed it. It's mandatory to do, it's good to do a pot before rewiring. It helps you. So flaring of the left main stent was done. And this was the second pot done. This pot was done with 408 NC.
Here I can ask you, Dr. Faiza. I think that's very good that you are doing each and every step. You are following each and every step. But can you can you guide me how did you decided that your wire is crossing through the proximal studs or distal studs? Because it's very difficult sometimes to identify that I'm crossing through the proximal studs.
Yes.
Angiographically.
Definitely. So basically, to finally, to conclude that, to find out whether I'm crossing via strut, which strut, I need to have, an IVAS or an OCT guided. But we did not have that. The best way to do that is that you let the wire in the circ and you get a new wire and cross it at the same position. But because we did not do that and we just see the angulation on the floor and had it done by that. But your point is valid. We need to keep the wire, the first wire, and get a new wire, either cross it with that or either you get a help from the imaging.
I think you can also use the stunt boot option.
Definitely, a stunt boost technique is definitely available.
Again,
yes.
This does not mean you can take another wire, but it should go to the opposite to the wire that you have already placed in the circ. For example, if your wire is jailed in the first position, then take another new wire that try to cross the other studs. That will help you in deciding that now you are going to the proximal stud, not the distal. Yes. Because most of the time jailing occurs through the distal part of the stent.
Yes. So, finally, we recrossed again. The second time rewiring done, which is the main step of the decay crush versus a mini crush. That's how we do our second kissing in balloon inflation. This was again done by a non-distal stud of the circ segment, and 3/12 and a 4/12 NC balloon was used for the second kissing balloon inflation.
What was the kissing pressure of both?
You have initially we did first we did in the side branch, then the main branch, and ultimately it was a simultaneously kissing. Initially we did the high branch, around I think it was 18 something or 10 at the side branch first, then this left, then the LED, and then simultaneously when we did it, it was approximately 10 to 12. With the simultaneously, you don't go high pressure, but when you are doing a stepwise kissing balloon, you need to go high pressure.
I think I can say here, Dr. As based on the Finet's law, we know now we have heard Professor Javed Akbarsial's speech. That Finet's law, actually it is 70% of the volume or diameter you have to achieve based on the D2 and D3. So if you are inflating the both balloons in the D2 and D3, so approximately you have to inflate to some extent to achieve the pressure of that you can achieve the diameter of 70% of the D1. So you can maximize your pressures based, you think that you have achieved the 70% of the diameter of the D1, then that's your optimal pressure. There is not written hard and fast that you can inflate up to 18 or inflate up to 20. Nothing has been written about it.
Did you do the IVAS post-op?
Definitely, it's
just
completely
wait.
incomplete without
we will show you,
IVAS.
just wait.
What was the MLA?
Definitely, and decay crush or any left main stenting is incomplete without IVAS. But before doing that, I would like you to see the final result on the angiography. So this was the final angiographic result. We can see a very well-defined carina and well-opposed stents on the angiography with a TB3 flow in both the circ and the LED with no distal dissections seen observed. So finally, a pullback was done from the LED to the left main. So we can see the IVAS image. So it can say well-opposed stents seen in the LED and no under-expansion seen. The MLA calculated at the LED was around greater than 6 and the left main was greater than 8. Lumen area, with the calculated lumen areas. Yes, इसी का IVAS है. So coming back for a quick revision of the decay crush. Thank you. Both the branches are wired and pre-dilated. We put a protection balloon in the main branch and a stent in the side branch. You inflate the side branch stent, then remove the wire from the side branch and do a crushing of the side branch stent with the protection balloon kept already there. After this, you can either get a new balloon or with...
Faiza, sorry to interrupt you.
Yes.
There's a very important step between after step 1 and between step 2. What is that important step?
At the pot? No.
After wiring, you have to pre-dilate both vessels.
I told that.
And
Before you pull the side branch wire out.
The protection balloon should not move. Something?
That's important, but you must take a picture.
Dissection is
Yes,
dissection,
definitely.
dissection,
Oh,
dissection.
definitely. We need to have angiographic. You know, even if not a cine, then get it check on the fluoro. We need to rule out that there is no distal dissection. Definitely. Crushing of the sideband stent and the pot is done so that it can facilitate you for the rewiring via the non-distal strut of the sideband stent. Then first case should be performed. Remove the wire from the circ and the balloons from the both branches and a main vessel stenting performed, which should be followed by a pot. Second time, you need to rewire again via non-distal strut and a second kissing balloon inflation, followed by a pot. So I think we have already discussed what are the complications that we can accept coming back while performing a DK crush. No need to go further into that. Just we know it's just a simple diagrammatic representation of the mini crush. The only difference between the mini crush and the DK crush is in this step. The first crush, basically in the mini crush, you put 2 stents simultaneously, and this first case is not there, which we can see in this diagrammatic representation. I'm not going to go into the detail of this. So coming up to the trials, just a brief. The syntax trial, we cannot go off. I mean, I think we should omit that because we have already heard so much about left main stenting today, the Excel, the syntax and everything. Just coming up to the basic trials of the DK crush. In 2015, the DK crush 3 study was published, which showed that distal left main bifurcation. DK crush is better than a Q lot. The 419 patients was taken. Randomly assigned to the DK crush or Q lot strategy, and the primary endpoints were 1 year MACE, the cardiac death, MI, and TVR. And what did this study show us? It showed that Q lot stenting for unprotected left main bifurcating lesions was associated with a significantly increased MACE, mainly due to the increased risk of TVR, so favoring a DK crush strategy. Ultimately, 2017 DK crush 5 came, in which basically for left main unprotected, for left main bifurcating lesions, a DK crush versus a provisional stenting was taken. Again, it showed that at 12 months, the DK crush was superior to the provisional stenting for the clinical outcomes. The clinical outcomes were a reduction in the TLR, the target vessels MI, and the stent thrombosis. So coming back to it, how has the evolution of the left main stenting has been done? 2015, DK crush 3 said that DK crush is better than the Q lot for this left main. 2016, the BBK2 study showed that Q lot is better than TAP, and ultimately in 2017, DK crush was better than the provisional for the complex lesions. So,
Dr. Faiza, just a minute.
Yes, you would like to enlighten us for...
Yeah, in a DK crush 5 trial, this is basically compared with the EBC main trial. That is the European trial, left main bifurcation club. And they also use the upfront two stent strategy and provolone stenting.
Yes.
The DK crush 81% use the bifurcation, along with 47% they cross over from provolone to the DK crush. And DK crush 5 trial was basically conducted in the 26 centers, 23 in the Asia and 2 in America and 1 in the Italy. But the EBC main trial was held in the Europe. The thing is that DK crush trial syntax was 13 and ABC was 21. Another main difference. But if you see the key findings in the DK crush 5 and the EBC main trial, they favor the provolone stenting as compared to the DK crush. And in the EBC main trial, the 53% do the kilo technique regarding left main, and 4% did the DK crush. And as far as we see the DK crush 5 trial, this is a more robust trial as compared to the other, because Americans are very strict regarding the revascularization in the left main. And another thing is that if you are commenting on the trial regarding the PCI versus cabbage of the left main, we see after the Excel and the Nobel trial, they changed the whole guideline.
Definitely.
The thing is that if you see the Excel trial...
But in the Excel trial, there was a low to intermediate risk syntax co patient were taking.
Yeah, the thing is that but the Nobel trial, is conflicting regarding the result of the Excel trial, because the Excel Nobel trial shows the non-inferiority of the PCI as compared to the cabbage, and the both trials are the follow-up only of 3 to 5 years.
So if you would like to conclude...
The thing that the whole world, the major concern regarding the PCI and cabbage is that we have not even longer follow-up. If you see the catch-up long-term, they kept most of the patient went through the PCI, ultimately they diverged with the cabbage. And the only 2 trials we have, that the syntax left main and the pericom trial. Both include the syntax score of 20 to 5 and pericom at 21. They have the 10 years of follow-up period.
Yes, both of them have showed that there's a PCI and cabbage, they both have the equal risk of mortality.
Can I add one thing to Dr. Mukesh's comment? No?
Yes.
He quantified the EBC main versus the DK crush fire. Definitely, EBC main said provision is comparatively good, and DK crush fire, the DK crush is good. But the difference was so many, as you pointed out. There was also one main difference that was the leading in that was the side branch. The average mean length of the 16. Side branch was 16 in the DK crush fire, while it was approximate 6 to 7 in EBC main. That was the trailing edge or differencing that led to the provisional standing better as compared to DK crush.
Okay.
And another thing, have you gone through the left main PCI or revascularization? If you see the pre-Excel and pre-Nobel guideline, 2014 European AHA, and the 2018 and 2021 post-Excel and the Nobel. Class 1 recommendation, PCI left main and low syntax score. I am major concerned regarding giving the level of evidence. Level of evidence is changed from B to A after Excel and Nobel.
Yes.
But the thing is that most important thing is that, as we know, the stable scheme heart is the contest point of view. The American usually follow 2 things. Key components, one is the clinical, other is anatomical. Clinical, if the syntax is STS score more than 5, and anatomical, the ostial or shaft left main, that is class 2A, level of evidence B.
Yes.
But in post-Excel and Nobel, there's class 2A recommendation,
may be
but still,
yes,
and they ignore the clinical and the anatomical component.
So rounding off,
if the result of PCI and cabbage is equivalent, that's class 2A, level of evidence B, post-Excel 2021.
You should look at me like that.
I think we still need a lot of debate about the decision, and we don't have long-term data. And already in the morning we discussed about a lot of strategies, but DK Kirsch has better results rather than provisional stenting, the trials shows.
No, see, I think Mukesh was discussing a different topic, and I agree with you. The American thoracic surgeons, they refuse to endorse these guidelines, because if you look at long-term follow-up of Excel, there's higher MI with left main stenting. And the composite of death and MI is in favor of cabbage.
Yes.
Okay, so, but you know, that is a separate discussion. Yes, you're right. In terms of longevity, those were patients. Now understand that in Excel and in Nobel, both the surgeon said that yes, I can operate, and the interventional cardiologist said yes, I can do stents. That's a very different patient subset from this gentleman, where a team of surgeons sit down and say, no, I think the patient is too high risk, you should do that. So the clinical context is fundamental to your decision making. Now, just a question for the panelists. Why do you think Coulott didn't do well compared to DK Crush, mechanistically?
I think the mechanistically optimization, that was a 3-time kissing, 2 times supporting port techniques doing in the DK Crush has had an overage as compared to Coulott. To me, I think so.
No, I think it's an angle is also very important regarding decision. And yes, Dr. Kamran, you want to say something?
I think the simple thing is that, by doing the DK crash, you are actually avoiding the triple layer as minimum as possible.
Yes.
So that's the basic key.
And your wire.
It's like you have 2 layers of stents, right? 2 layers of stents would always have a higher TLR rate than a single layer. And Goulart, you by design would leave at least 8 to 10 millimeters of stent. So you'll have 2 layers of stents in the left main for at least 8 millimeters.
While you're going for the selection criteria of the Goulart, there's a difference between the LAD and the circumflex. And in DK crash, your main vessel, your wire will remain
in the main branch. Yes, you don't have to remove the wire from the main branch. So, a left main bifurcating stenting, if it's a simple left main disease, a provisional stenting can go. But if it is a left main complex, a 2-stent strategy should be your major concern. Final thoughts on my lecture. Most unprotected and most left main disease can be readily done. 6 French can be cumbersome but can be done, can be helpful. Hemodynamic support should always be there, and imaging should always be there. So about just a bit of technicalities, whenever we want to stent a balloon in the distal main vessel, it should always be according to the distal branch. Do not oversize. We should always keep the reference of the distal vessel. And each time we deploy a stent in the main branch, we need to do a pot. And each time a stent is deployed in the side branch, we need to rewire and do a final KBI. So the sequence for any bifurcating disease should be a pot, a rewire, a kiss, and a report. I would emphasize you on this: a pot, a rewire, a kiss, and a report. So this is, I think, if we can all remember this one line, it will be helpful for us. So doing a kiss, a sequential kiss, which should be followed by a simultaneous kiss. And ultimately, why we did not opt for a cabbage and a PCI. So, thank you.
Okay, one other thing, because we have to look at cost effectiveness. DK crush requires a lot of equipment, but this case was done with
a minimal
2 wires, 3 balloons, and 2 stents.
Yes, I think many of them have not noticed the final kiss was the final pot was done with the 2 balloons, and they did not notice that.
All right, thank you everyone.
Thank you.
Thank you everyone for excellent discussion. Thank you.